like to start the session by bringing up Dr. Ava Yap, who's going to be presenting on the impact of investment in pediatric surgical infrastructure on income equity in Ethiopia.
We'd like to disclose that Charity Kids OR funds the OR installations and the data collection procedures for the study. 1.7 billion children have no access to surgery worldwide, and most reside in low and middle income countries, or LMICs, such as those in sub-Saharan Africa. These areas have a poor investment in hospital infrastructure. Our study site at Menelik Hospital in Ethiopia was no different. This large government facility predominantly serves poor patients, but the lack of surgical equipment for children led to unnecessary delays in care. In August of 2019, the Charity Kids OR installed a pediatric operating room to alleviate this problem, and the facility is now used to reduce the backlog of elective cases. Therefore, we sought to address the impact of having a dedicated pediatric operating room on surgical volume and outcomes from the perspective of income equity. We conducted a single-center cross-sectional cohort study. We administered an economic survey to caregivers during their child's surgical admission and collected patient demographic and clinical data via chart review through hospital discharge. Children aged 15 years or younger who underwent elective surgery from August 2018 to April 2022 were included. We excluded time periods of extraordinary events such as that disrupted cases, such as the COVID-19 lockdown. The primary predictor was presence of a dedicated pediatric OR. Primary outcomes were surgical volume, disability-adjusted life years or DALYs averted, and families' net monetary health benefit. Secondary clinical and economic outcomes included out-of-pocket costs and catastrophic healthcare expenditure, or CHE. CHE was defined by spending more than 10% of annual household income to pay for surgery. Descriptive statistics was performed for patients' baseline characteristics, while changes in surgical volume over time comparing pre- and post-OR installation were analyzed using interrupted time series analyses. The monetary health benefit for surgery was calculated using the value statistical life year, or VSLY method, which is a measure of human capital to capture the productivity of healthy individuals. The net monetary benefit was divided by the patient's family household annual income to find our income equity ratio. We proposed this method as a novel way to demonstrate economic equity such that poor individuals had relatively larger gains. Currency was reported in US dollars in 2022. In total, 950 patients were included. The median patient age was 3 years old, and the majority who underwent surgery were male and ASA Class 1. Post-installation, patients were more likely to be younger and female, and surgeries involved more surgical and anesthesia providers and trainees. In the pie chart comparing the case mix before and after OR installation, more patients had gastrointestinal congenital anomalies treated post-installation. Compared to pre-installation, DALYs averted were higher per case post-install, as were utilization of the safety checklist and postoperative antibiotics. The rate of postoperative in-hospital complications was low at 1 to 2% and included sepsis, surgical site infection, and reoperation. In our ITSA model, surgeries were occurring at a baseline of 16 cases per month without significant change over time before OR install. Immediately after, surgical volume increased significantly by 24 cases to an average case count of 40 per month. After initial uptick of cases, the surgical volume remained unchanged over time. 339 patients and their caregivers completed a self-reported economic survey, a response rate of 36%. In the cost arm, the median annual household income was $1,300, and 28% fell below the poverty line. The median out-of-pocket cost was $122 per family, and CHE occurred in 41%. In the benefit arm, the median DALYs averted per patient was 17, and the net monetary benefit was $80,200 per patient. In the cost-benefit comparison, our income equity ratio was 60. To summarize, we found that installing a pediatric OR in a public Ethiopian hospital increased surgical volume immediately, with more procedures that averted a higher disease burden and no change in postoperative complications. Additionally, the space allowed for more surgical and anesthesia providers and trainees to participate, providing a training program. Pediatric surgery at this facility also allowed for families to retain 60 times their household income in monetary health benefit, and this was especially for patients who were most impoverished. Nevertheless, families still incur CHE without financial protection. Universal healthcare coverage is therefore crucial to improving access to pediatric surgical services in Ethiopia and other LMICs. We acknowledge that the single-center observational design limited generalizability. Disruptions due to the pandemic left a significant gap that may have reduced statistical power, and including only elective cases also meant that disease burden averted may be underestimated. But while this selection bias led to more conservative measures, our study still found a sizable difference after OR installation. I'd like to thank our collaborators at Menlo Lake Hospital and Kids OR for making this study possible. Thank you.
If I could ask, this is a great study and a really unique way to kind of look at economic benefit. Is there any thought about comparing your data to a system where there's no dedicated pediatric OR and ORs in general have to be shared with the multitude of other surgical cases in a system?
I'm so glad you asked that question because that is also another passion of mine, and I think you're sort of alluding to a cost-effectiveness analysis. So we've actually done previous work addressing that exact question. We've looked at cases in Uganda, and we published on this as well, and it's actually extremely cost-effective when you compare it to a scenario where there's no pediatric operating room or capacity. I think the incremental cost-effectiveness ratio was about $35 if you look at the whole societal perspective. And that is in comparison to, for example, cardiovascular drugs, which is about $300, or C-section, which is also about $300. And this is in the low and middle income country setting. So yes, this is definitely a question that requires comparison and relative economic benefits. Thank you.
All right, if there are no other questions, we'll move on to the next presentation. Thank you. I'd like to welcome Dr. Carolyn Stevens to present her paper entitled Impact of Bowel Coverage on Gastroschisis Mortality in Low-Income Countries, Experience and Lessons from Uganda.
My name is Caroline Stevens, and I am a fellow at the UCSF Center for Health Equity and Surgery Anesthesia. I am presenting this work on behalf of our collaboration with the pediatric surgery team at Malago National Referral Hospital, the Pediatric Surgical Foundation, and Stella Pneumonia. Thank you for the opportunity to present our work. We have nothing to disclose. In all of pediatric surgical disease, gastroschisis has the greatest disparities in patient survival between high-income countries and low-income countries, with an estimated HIC mortality of less than 2% and greater than 90% mortality in LICs. These problems are particularly prevalent in Uganda, where a 2014 study demonstrated a mortality of 98% for all neonates with gastroschisis. The reason for these disparities are many, from lack of prompt referral, insufficient resuscitation, development of sepsis, lack of neonatal intensive care resources, and parental nutrition. In order to address these disparities, multiple quality improvement efforts were undertaken. First, a protocol was created to allow for bedside placement of silo bags with stage reduction, starting with the use of altered sterilized urine bags, then laparoscopic wound protectors, and finally with donated spring-loaded silos. All of these materials are sterilized between patients to allow for continued reuse. Then, in 2020, a protocol was developed that included standardized guidelines for neonatal resuscitation, focused on prompt management of dehydration and initiation of antibiotics, as well as early enteral feeding. And lastly, concurrent with these efforts, the team also developed a community outreach program focused on education of healthcare workers with the appropriate focus on initial resuscitation, management, and referral of patients in with focus on pediatric surgical emergencies. We sought to specifically assess the impact of different methods of bowel coverage on outcomes for neonates with gastroschisis compared to historic controls. We performed a retrospective cohort study of all children admitted for gastroschisis between 2017 and 2022 and compared them to historic controls in 2014. Notably, due to a 2019 change in ward location causing data loss, all children managed in 2019 were excluded from the study. Our primary outcome was in-hospital mortality, and we secondarily examined changes in referrals over time. Risk ratios were used to assess impact on mortality, and the John Curry test of trend was used to assess the referral trends over time. After excluding all patients with no documented discharge disposition and who presented in 2019, we had a final cohort of 368 patients. The majority of infants presented in the first day of life, and there was no differences in demographic data. Most children came from surrounding districts, with referrals primarily coming from central Uganda. Overall, significant differences were found in the cumulative mortality of each cohort compared to historic controls. While trends between cohorts were inconsistent, the greatest reduction in mortality was noted both in 2018 and 2022 when 34% of neonates survived. And, as you can see by the survivor cases highlighted in yellow, a large volume of patients survived following the introduction of the resuscitation and enteral feeding protocols, as well as the transition to spring-loaded silos. This translated into an estimated relative risk reduction of 0.67 to 0.77 for use of bowel coverage methods. And additionally, of those neonates that did not survive, the length of life was also noted to double, with some neonates living for over 1 month. In regard to the change in referrals over time with ongoing outreach efforts, a significant increase was noted in the rate of referrals, with an average of 3.7 referrals per month in 2017 compared to 8.8 per month in 2022. Overall, we found that bedside application of any type of silo can save the life of 1 in 3 children with gastroschisis, even in the absence of TPN. Additionally, the combination of care protocols with ongoing outreach efforts was associated with a significant increase in patient referrals, increasing overall countrywide capacity to treat gastroschisis in Uganda. Our study did have a few limitations. First and foremost, it is a retrospective and observational study using a prospectively maintained database of pediatric surgery inpatients, which limits the collection of clinical characteristic for additional analyses, as well as control of confounding factors. Additionally, this represents a single center experience, which may limit generalizability of the findings, and due to the rarity of the condition, the sample size is small. Lastly, while not part of the study, we additionally want to recognize the ongoing efforts of our colleagues who are working to create a low-cost silo that could be produced in Uganda, which would not only support the ability to treat gastroschisis, but also help develop medical device manufacturing and innovation capacity in the country. We would like to acknowledge that this work is a result of collaborative efforts between the pediatric surgical team in Uganda as well as individuals in HICs, all of whom support the work of the Ugandan Pediatric Surgical Foundation, which seeks to reach beyond patient care to provide workshops and trainings to other Ugandan providers, as well as outreach efforts to rural areas. Thank you.
Can you comment on the cost of each of these methods? It was nice to see the evolution up until now, but one concern I had was whether or not this was sustainable as the silos were donated and quite expensive.
Yeah, so the urine silo, or the altered urine bags, are basically using existing resources that are in country, which is quite cost effective, although there's been many concerns raised by multiple surgeons regarding issues with the bags that result in bag fracture, as well as increased risk of abdominal sepsis, and so that's why they've gone away from this approach. For the Alexis wound retractors, which is the improvised silo, costs about $25, and then Benetech silos cost $300 per silo, although they are sterilized for continued use. And Benetech has actually expressed significant interest in continuing their donation efforts, but I think this gets at our last slide, which is that the overall goal and part of what the ongoing partnerships are focused on is running actual trials with a locally manufactured silo, so they can have a silo that they make and utilize themselves that's made in country, and this would also increase capacity for silos throughout East Africa.
Okay.
We have a virtual question. The comment is, we use blood bags as silo bags. Any comments or experiences with that?
So my understanding from our team and our collaborators is that they not use blood bags, but I know we'll hear another presentation later in this talk talking about, for instance, an altered use for an IV bag. I know our teams in Mbale often use female condoms. I think you'll find very differing experiences based on each team, but I think there's many ways to potentially modify existing resources to create a silo that could be used for patients.
Hello, I'm Fernanda Lage, I'm from Brazil, and I would like to say exactly this. I use blood bags without anticoagulant, and it really works. And I would suggest that if you get away of these pre-prepared silos, you can use anticoagulant bags.
Thank you so much.
I think we have time for one more question.
Jean-Martin Laberge from Montreal. Congratulations on improving the survival. It's fantastic, and I'm sure you'll keep going. Have you looked also at age of referral? You showed the number of referral per month, and you say it's a rare condition, but many centers in North America see 5 or 6 cases per year. You're seeing 5 or 10 per month, so it's not so rare in your country. So in relation with the birth rate also, I don't know if you can make a comment about that. Is it more frequent, or is it just that the population is so huge?
I think that's a really difficult question to answer given the limitations for data collection countrywide, but I do think it's definitely a common problem that often goes unaddressed. We did look at age of referral. 60% of patients were referred within the first day of life, but that leaves actually a large proportion of patients who are referred on day of life 2 or 3 or greater. And in comparing different congenital anomalies, which we have done, like we're doing a current, for instance, ongoing project on looking at jejunal and ileal atresia, there's a major difference in the time of referral for those patients where the jejunal and ileal atresia are often referred at over a month out from life, but there's an earlier recognition of gastroschisis because it's more obvious. Another challenge, I think, and a big potential area for improvement is improved recognition with prenatal ultrasound, and prenatal ultrasounds are more frequently being performed in this setting. However, often people report the sex and they don't note that actually the bowel is on the outside of the abdomen rather than the inside, and if there was better coordination, especially with increased capacity for maternal fetal medicine, I think that would save a lot of lives and result in more children being delivered locally so they could get appropriate care in a timely manner. Thank you.
Thank you. Our next presenter is Robin Petrozzi. Her paper is entitled 12-Month Prospective Analysis of Neonatal Surgical Outcomes in a Low-Income Setting, Identifying and Addressing Modifiable Risk Factors for In-Hospital Deaths.
Thank you very much for the opportunity to present. I am presenting on behalf of my research fellow, Dr. Tom Deal, and our pediatric surgical team in Rwanda. We have no disclosures, but the work was partially funded by a Fogarty Fellowship. As we've heard, there are dramatic global disparities in health outcomes and opportunities around the world. And it's come as no surprise to this audience that children are unequally affected by those disparities. Sub-Saharan Africa has the highest global neonatal mortality, with 27 deaths per 1,000 live births. In fact, a child born in Sub-Saharan Africa is 11 times more likely to die in that first month than a child born in Australia or New Zealand. So why is this? Let's consider the management of a neonate with esophageal atresia in 2 very different settings. Neonatal care requires a multidisciplinary approach, and many of the interventions for improvement may exceed the community level and require complex system and hospital level strengthening, as well as the development of critical care capacity. Our group in Rwanda recently completed a retrospective analysis of neonatal surgical outcomes. While factors in transport and late arrival certainly contribute to mortality, we were most impressed that in-hospital mortality, particularly that due to sepsis and antimicrobial resistance, have significant impact on outcomes. So what could we change? We therefore implemented a prospective neonatal surgical registry in Kigali, Rwanda, to identify modifiable risk factors for in-hospital death. Our goal is to collaboratively design interventions to improve survival and build hospital-based neonatal capacity. Today, we'll present our 1-year outcomes, specifically focusing on infectious outcomes and any predictors of survival. For setting, Rwanda is a low-income country in eastern sub-Saharan Africa with a total population of 13 million. The University Teaching Hospital, or SEASHKA, is a 520-bed tertiary care hospital in the capital city. It's one of 4 referral hospitals, but the only with a comprehensive pediatric surgical and anesthesia service to care for neonates, as we'll hear from my colleague later. The majority of patients are outborn and referred in, but not able to reside in neonatal units due to infectious risk. Some of the resources available at SEASHKA include a 3-bed PICU with limited neonatal ventilation, a high dependency unit, as well as a 10-bed neonatal surgical unit that opened in 2020. There's a dedicated kids OR, there's 2 fellowship-trained pediatric surgeons at the hospital there and a fellowship training program. There's no TPN. This was a prospective registry with daily bedside data entry by a trained Rwandan nurse registrar. All neonates with surgical admission diagnoses were included, with some of the key registry variables listed here. We performed rigorous quarterly audits to ensure accuracy and completeness, and our prospective capture rate was 88%, with missing files entered retrospectively. During the first 12 months of data collection, there were 223 surgical neonates. Overall survival was just over 50%, with a variable mean length of stay of 17 days. Survival outcome for the first 12 months and most common diagnoses are reported here. My residents in Rwanda think that the most common pediatric surgical condition is gastroschisis, which represents 55% of their neonatal surgical volume, with an overall survival of 39%. And my colleague's presentation later will talk about those patients. Intestinal atresia was most common, with a survival of 67% with no TPN. And esophageal atresia was next, with 48% average over the 12-month period. Interestingly, we noted poor survival in the first 6 months, where only 25% survived. We presented this to the group, and changes were made. Obviously, this is very multifactorial in terms of age at referral, issues of prematurity and comorbidities, but it does highlight the role of the registry in ongoing quality improvement. Our data demonstrated that higher birth weight, more expedient time to operation or abdominal closure for gastroschisis, and fewer new peripheral IV lines were associated with survival to hospital discharge. In fact, the availability of routine blood culture data demonstrated a trend toward significance, with 12% greater survival when blood culture bottles were available and used. Looking deeper at the culture and antimicrobial data, 95% of neonates received antibiotics on admission, with this choice in line with national guidelines. Practice pattern is that cultures are obtained at admission or when there are clinical signs of new onset sepsis when culture bottles are available. We had a total of 135 blood cultures, with just over 38% positive, excluding coag-negative staph. We found more than 50% resistance to the first-line agents. Importantly, as neonatal capacity increases, the potential role of antimicrobial resistance in sepsis management cannot be underestimated. What we have found, though, is that care of the surgical neonate requires a multidisciplinary approach. This includes advanced nursing, anesthesia, ventilation, nutritional support, but this can be performed in low-resource settings, and improving this for surgical neonates can be expanded to other neonates. Sepsis is a significant contributor to in-hospital neonatal death, and we identified high levels of antimicrobial resistance. This is not a risk-adjusted study given numbers, but we do have some of that available. And there are some gaps due to funding or constraints within the unit. Culture data are available intermittently due to supply chain shortages. We are looking at nutrition protocols as well as trying to identify ways to obtain better intravenous access and decrease infection risk. Be more than happy to take any questions, and I want to congratulate Tom on his year in Rwanda, which he did during a pandemic with a 1-year-old, and was accepted into the group quite well with his local team and the mentorship from Dr. Ntaganda. Thank you.
That's a really nice paper, and congratulations on pulling this off in a prospective fashion. I thought the PIV data was very interesting, Robin. Can you talk more about that, or do you think that the number of PIVs was actually a surrogate for sicker kids who would have had a higher mortality anyway?
So there are not central lines available, and so oftentimes the peripheral IVs are lasting anywhere from 2 to 4 or 5 days if they're putting peripheral lines into IJs or if they're surgically placed by the surgeons. Some of the biggest was that Dr. Edmonds' hypothesis was that there was some nosocomial infection because of only having 1 or 2 nurses in the unit and them spending about 80% of their time trying to find new IVs. And the supplies in that required so that if we could decrease some of that. So part of the midline study as a QI, very small numbers, was kind of charting how much time the nurses spent and having observation of some of their hand hygiene and that sort of thing as well. And so there's a lot of protocols in that to be developed, but the hypothesis that the more hands-on and the more manipulating of the neonates related to more infection. So the more pricks, as Edmund will say, the more infection.
All right, thank you. We have to move on to the next paper. I'll invite Dr. Samuel Nagash to discuss his paper. Sorry about that. Paper entitled Social Impact of a Colostomy on Families of Children with Colorectal Disorders.
Okay, thank you for the introduction. My name is Samuel Nagash. I'm a pediatric surgeon from Addis Ababa, Ethiopia. I have nothing to disclose. So colostomy is one of the most commonly performed procedures in pediatric surgery in my practice, and there have been no studies to assess its social impact, but from the few studies that have been done in other LMICs, it has a significant impact. From my experience, we have observed that there was a high complication rate in patients who had a colostomy, medical complications that is, and also patients stay for a long period of time on a colostomy because of the waiting list we have, and there are no stoma appliances, there are no educational materials in the local language, and also there is a social stigma towards congenital anomalies, and some of the parents would choose to take their newborn home to die rather than have a colostomy. So the objective of the study was to quantify the burden of this colostomy on the psychological, social, and economic lives of our families, the families of our patients, so that we could provide better counseling and care. So we used mixed method studies, collecting both qualitative and quantitative data, and we interviewed 30 parents of these children, and we interviewed them just after the colostomy was closed or a pull-through was done in order to avoid bias. So we found most of our participants were mothers, and they were married with a high school education and most living in urban centers. And mostly they were housewives or unemployed, and they were young with a mean age of 30 years and a monthly household income of $170 US. The most common indications for colostomy was anorectal malformation and Hirschsprung's disease in around half and half. And mostly they were done as an emergency. The indication was urgent in 87%. And the mean age at colostomy was 6 months, and on average patients stayed on a colostomy for 2 years. And the most common medical complications that they had was peristomal excoriation and the bleeding from the stoma site. So when we tried to assess the knowledge, we found that most of the families have never heard about or seen a stoma before, and they were also not satisfied with the counseling that they got preoperatively as well as postoperatively. And they had severe anxiety as a result of this factor. Most of the information that they got was from other patients who had the same condition. The appliance that they used to care for the stoma was they covered it with a cloth wrapped around the waist, most of them, around 43%, and the others used a second diaper over the abdomen to cover the stoma. And none of them used a colostomy bag. And the reason they stated was that no one told them about it. They didn't know about it in 77%. The others who know about it couldn't find a proper fit because it was no pediatric size, and also others said it was expensive. So this is one quote from a father who said, "We used a waistband, but it caused excoriation. We have now stopped covering the stoma and leave it open for the child to soil her clothes. And we have to wash the clothes frequently, up to 3 times a day, and we also cover her bed in a plastic sheet when she sleeps." So this is a problem faced by many parents, and the children either drop out of school or never go to school if they have a stoma already. There was only one parent who developed this innovative stoma appliance using locally available material of this IV bag, and those were the only, that was the only child who was able to go to school from our study. So it also had a significant psychosocial impact on the parents. So most of the parents said that they felt isolated from the community because they were not able to go to social events. They were embarrassed and ashamed that people would see their child's stoma. And when people see it, they were uncomfortable. One mother stated, "People are disgusted and tell us to take the child out of their sight. They are frightened and make the sign of the cross and they have told me that there is no hope for the child and that I shouldn't waste my money on her treatment." They also had problems internally in the household, with around 1/3 reporting that they had conflicts with their spouse and family due to the colostomy, and a couple of families also had divorced because of this. One mother said that her husband left her because he thought it was her sin that caused this disease on the child. When we see the economic impact, the expense to take care of a colostomy on average monthly was $14 US. And most of our patients were already under the poverty line, 46%. So after the colostomy, this increased to 65%. And 1/3 of the patients also had to quit their job in order to take care of the child with a stoma. When we try to compare with other studies, we found similar themes in the 2 other studies that we found. This was a study done in Honduras and also one in Uganda. So in conclusion, we found that there was a higher rate of psychosocial problems associated with a colostomy in our setting related to both the society's understanding and also economic factors. So our next steps would be thinking of ways to get the surgery done for these children earlier, and also having nurses and training on stoma care. And also we should look for locally made solutions for stoma appliances. I would like to acknowledge my co-authors and also the UCSF CHESA team for their guidance, and also the participants of the study who took their time to let us know about their condition. Thank you.
Monica Langer, Chicago. Thank you for this great study highlighting a real problem that I've seen in Uganda and Tanzania as well. Have you thought of doing other things to limit the number of stomas you have to make? I know there's some studies out of Nigeria advocating for 1-stage procedures instead of 3-stage procedures. And so far there's reluctance at the institutions I work at to do that, but I was wondering if you have explored that.
Yes, so we have done that. So one of the things that we've already done is, one, to give priority for these children on the waiting list so that they would get operated earlier than the other children. And also, for example, for Hirschsprung's disease, we started doing primary endorectal pull-through, even though we don't have frozen section facilities. And we've actually published on that there is no significant difference. And also, we've started doing 2-stage procedures for some of the lower anorectal malformations.
Thank you.
Thank you.
Andrew at Children's Colorado. Fantastic work. Thank you so much for doing this. We really need this. The 2 quick questions. One along that line regarding Hirschsprung's disease. Would rectal irrigations also be a death sentence for many of these kids? I suspect it would if you were to send them home with that alone. And second question is, any ideas for what you feel would be an inexpensive bag for these colostomy patients?
Okay, so regarding the rectal irrigation, so we are very selective of the patients we don't do colostomy for. So they have to be able to reach the facility, so they have to live close to the city. And they also have to have well-educated parents that could follow up with this, doing this procedure at home. So we also assess not only like the length of the aganglionic segment, but also the social condition before we decide whether or not to do a stoma. And for the other condition, I mean, we're learning from our patients. So this guy that did it, he actually took a ring from another stoma bag, an adult stoma bag, but then he used the gauze to tie it around the waist, and he used the IV bag, the plastic bag, so that he could empty it and wash it and reuse it. So I think that's a good solution that he made. Yeah.
Hi, Brittany Grayson, Kajabe, Kenya. Great work. Congratulations on this presentation. I was wondering, and I think this was on one of your slides, but if you could comment about maybe the loss to follow-up in your patient population, and if you think that was related largely to these social stigmas. So are the children not being cared for and suffering infections and not ever coming back to your hospital? Or did you get a sense for why, if there was a large loss to follow-up, why that was?
Actually, there was not a large loss to follow up after they had the stoma, because they were eager to get the stoma closed. But before they had the stoma, we have difficulty convincing some of the patients to get a stoma. And some of them would refuse and take the child, even though they had like an severely obstructed with anorectal malformation, a neonate, they would take them home instead of getting the stoma. So we've seen that in some patients. But once they get the colostomy, usually they want to come back and get it closed earlier. Thank you.
I'm sorry, we're out of time.
Thank you.
Our next presenter is Stefan Trinidad, presenting on pilot bowel management programs at Mbarara Hospital, Uganda.
Thank you. And just to say this was a fantastic transition, so thank you for your work. This talk is really the results of a partnership between providers at Cincinnati Children's Hospital, at Embrar Regional Referral Hospital as well. We have no disclosures to present. For some background, as you are all aware, kids with anorectal malformation and Hirschsprung's disease often suffer from fecal incontinence. This is common in high-income countries. These patients will benefit from formal bowel management programs. These programs can help them remain free from stoiling, significantly improving their quality of lives, allowing them to remain in school. In Uganda, as is the case in many low-income countries, there were no formal bowel management programs for these kids. In Embrar specifically, after definitive management for anorectal malformation, nearly half of the patients still report daily soiling. So this is a common problem that they face. And with this, there's significant morbidity. So all of the school-age children that we were aware of in this program, if they had daily soiling, they weren't attending school. Common refrain that we got was that they were chased out of school because of this issue. So given this, the team at Embrar had a vision or a goal of starting a bowel management program to help these kids out. And so we sought to assist them in this. And so we first conducted like a resource and population assessment to understand what their goals were and who we were treating. So the population was largely children with anorectal malformation or Hirschsprung's disease who had already completed kind of definitive management, but were still suffering from daily fecal incontinence. These are the staff that participated. The resources that we looked at included things like the physical space that was available, the radiological capabilities, the pharmacology that they had, what did they have access to. I want to point out one thing regarding the pharmacology. In Uganda, they had a really hard time getting laxatives. They just were cost prohibitive when available, but enema supplies were widely available. You could get soap, you can make saline. And so given that we were treating a population with significant morbidity, these are kids that have gone untreated with Hirschsprung's or anorectal malformation, and kind of widely available enemas with difficulty getting laxatives, we decided to do an enema-only initial program. The program consisted of about 10 days. Initially, we did surveys of both patients, their families, and providers. In the first day, we then conducted an evaluation, followed by a clean-out, and then after the clean-out, there was kind of daily titrations of the therapy until they reached enema therapy that was working for them. Throughout this, initially there was more hands-on participation by the partners in Cincinnati. By the time this program was done, the staff in Embrar really were owning this. They were doing the titrations, they were counseling the patients, and they provided the counseling back to home. So it was really amazing to watch. Following this, we did follow-up surveys at 2 weeks and then at 6 months. These are the patient demographics. It was intentionally kept small as a pilot program to see kind of whether it could be effective. So we only treated 12 patients. The median age was about 4.5, as might be expected. I just want to highlight one or two things. So looking at the initial x-rays, all 12 had very, very significant stool burdens. 5, you could easily identify stool balls even on the x-ray. And then 11 were started on daily enemas. 1 was started on irrigations instead of enemas because of concern for like a megarectum. So looking at our survey results, this is looking at the daily daytime soiling events. And so this is before the bowel management program. And so you can see that 10 out of 12 patients are reporting at least daily. Most are reporting multiple daily soiling events, impacting their quality of life. Following this, you can see the dramatic shift to the left, where most patients are now reporting that they're remaining free from soiling. At 6 months, we were able to follow up with 9 of the 12 patients. 3 had difficulty reaching Embrar, kind of following back up. Similarly, you see the very significant morbidity early on with everyday or multiple daily soiling events. And then following this, you see the dramatic shift with 7 out of 9 having no reported soiling events in the last several weeks. A couple other follow-up points. 8 of the 9 families are still continuing daily enemas. The other one is reporting weekly or a couple-time weekly enemas instead. All 9 report challenges with replacing equipment, particularly Foley's or enema bags. 3 of the 9 report even challenges with the enema supplies, so the soap for the enemas. Despite these challenges, all 9 families say they would do it over again. And all 9 families would highly recommend the program to other families, other parents in the same situation. Lastly, we looked at provider confidence, managing fecal incontinence. And so you can see that before the program, most providers were either average or below average in their self-reported confidence managing this condition. And then following this, there's a dramatic shift to where they're very confident. And then further highlighting this, the program there is now enrolling new patients. They're managing patients independently following this pilot program. So in conclusion, bowel management principles can be applied to low-income setting. If you have a patient population with significant morbidity, you can consider enema only as an example. But either way, local ownership is absolutely essential. And there are a number of future directions that we hope to take this in. These are our references. And I just do want to highlight the senior author on this study. This is Dr. Martin Satuma. He was the head surgeon, pediatric surgeon at Embrar, tragically passed away last summer. But this was his vision. This is why we have this program. He had a hope for treating these patients and seeing this through. So I wanted to honor him. Thank you for your attention.
Thank you. Go ahead.
Hi, Stephen. I'm Iris from Kansas City. We've worked together in Cincinnati. Really great job. My question for you is, typically with our bowel management program, we start with a contrast enema with these children, and I saw that there wasn't any. Yeah. So are you saying that we can, this was not done with a contrast enema, correct?
Correct.
Okay, so we're able to actually do bowel management without it in these settings?
Yes.
Awesome.
So a big part of this is learning even from our kind of low-income settings. And so, at Cincinnati, we also do daily x-rays as an example. We were able to get x-rays initially to get a sense of kind of the dilation of the bowel, to get a sense of the stool burden, unable to get contrast enemas regularly. And then we only did x-rays selectively as another example. It was usually 2 or 3 times over the course of the week instead of kind of daily, just because it's hard to get access to.
Okay, great job.
Thanks, Robin Petrozzi of Florida. This is fantastic and certainly a need. Is there any discussion with the local team in terms of the use of telemedicine, cell phones, pictures, et cetera, so that families don't have to travel, and in employing or using families as coaches for other families?
It's a great question. I know that the team often uses phone calls and following up. So, all these 9 patients had to be contacted several times by phone over the course of their study period, kind of 6 months. I'm not aware that they use any other means like video chatting or something else. And then I don't think we've brought up the idea of family coaches, but it makes sense. I know there's a lot of support groups around, even Stoma Care, and so it could be applied here.
Hello, I'm Fernanda from Brazil. I was surprised at how the families accept the enemas. For me, it's really hard. I have a bowel program there. It's since 5 years since I began. For me, it's really hard for them to accept the enemas, but I use local plants, the tea make of local plants, so you can use that as laxatives and try. They have their culture there, they have their knowledge there, and I think it would be easier to take care of this instead of enemas and all the supplies, and they don't have the supplies, and it's an option.
Yeah, it's a great point. For a lot of these patients, I think there's disease process, the pathology is fairly severe, very significant stool burdens. I think there's a concern that even if we had laxatives therapies, whether it would be enough initially at least, although the goal is to transition to laxatives for a number of them. The other point that I do want to highlight was that we were really actually amazed at how quickly these families took to it. Part of this is that the setting was a large surgical ward, so they were kind of all observing each other. And within the first day or two, it was really the families that were doing it. It was really neat to see one mother come up to another mother and help them troubleshoot with the Foley balloon, kind of pulling it back and inflating it more. And so I think because they're dealing with the morbidity of kind of daily soiling, and it's the mothers that it impacts dramatically, they had a huge buy-in. It was really amazing to watch.
Thank you so much.
The next abstract is entitled Improvised Low-Cost Silo Bag Using Widely Available Materials and Simple Assembly to Manage Gastroschisis in Low-Resource Settings, presented by Vanshika Jonsa.
Hi, everyone. My name is Vanshika. Oh, sorry. Okay, thank you. And I am a recent grad from Rice University, and I'm here on behalf of the Rice Global Health Technology Department. So yeah, thank you for giving me the opportunity to speak. So as Caroline was saying earlier, the mortality rate for gastroschisis in low-resource settings is close to 100%. And the reasons for this are multifaceted, but one of them is the fact that the high cost of silo bags make them quite inaccessible in low-resource settings. So in high-resource settings, the silo bags, such as the one pictured on the screen, can cost upwards of $200. Alexa's wound protectors can also be used. However, in low-resource settings, makeshift silo bags are made from materials such as urine bags, surgical gloves, even fabric in some cases, and these run into many issues due to the shape, infection risk, and the need for an OR. So recently, there have been a few teams trying to tackle this issue and the disparity caused by this issue. So today, I'm going to present the solution that my team came up with. So our mentor, Dr. Knight, came to the Rice engineering department, and she kind of gave us these objectives. So we really wanted to be able to make a low-cost silo bag using materials that are readily available in hospitals. We wanted to be able to emulate the characteristic cylindrical shape of silo bags, as well as the spring-loading mechanism in the ring. And we wanted to minimize leakage and make sure that our bag could be reusable. So this is the solution that we came up with. We used an IV bag and oxygen tubing along with a heat sealer. So in order to create our prototype, we first cut off the base of an IV bag, and then we formed a ring using oxygen tubing and whatever adhesive we had on hand, so we just used tape. Both the diameter of the ring and the size of the cut at the base of the bag are customizable based on the size of the gastroschisis. We then heat sealed the tubing into the bottom seam of the bag, so we created that spring-loading mechanism that allows the ring to pop into place under the baby's fascia. We did a few tests with our bag to make sure that they performed similar to manufactured bags. The first of these was leakage testing. So we tested with 3 different samples, and we found that the leakage rate was 3% leakage by volume, which is very comparable to manufactured silo bags. We also tried it with sterilization. So we sterilized one of our bags 5 times, and we found that the leakage rate only increased by 1%, which means that it is still comparable to manufactured silo bags. We also did strength testing, so we wanted to make sure that the heat seal seams that we had implemented didn't rip apart due to the mechanical force used in serial reduction. So we found that our bag actually outperformed commercial bags in this area. The green line on the graph is where commercial bags kind of break, so at around 40 newtons of force, and then all of our bags were at about 113 newtons of force. Lastly, we did effectiveness testing. So in animal models, we used cow intestines, and the first picture here at day 0 is right when we fastened the bag onto the intestines, and then at day 3, we can see that there's about a 50% reduction as the intestines have reduced into the container in the bottom. So overall, the cost of our bag is a little under $7. Here, the limiting factor is really the use of the heat sealer, but we found that many facilities actually already have these on hand. So if this did not need to be purchased, the cost would be well under $5. We also found that a lot of times these bags are made as needed. However, if a waged employee was employed to kind of make these bags, the total cost, including the in-labor country wages, would be under $10. So overall, our bag uses readily accessible materials, and it effectively reduces the intestine protrusion in gastroschisis. It is strong and leak-resistant, and when our mentor, Dr. Knight, took the bag to surgeons in Kenya, they had high satisfaction rates. So yeah, in conclusion, our bag is customizable, functional, affordable, and accessible. And in the future, we are currently planning a randomized clinical trial in different countries in Africa to really test the efficacy of our bag. I would like to thank our mentor, Dr. Bindi Naik, as well as our educational mentor, Dr. Bond at Rice, and the rest of my team. So thank you for this opportunity, and I'll take questions.
Again, Andrew at Children's Colorado, thank you so much for doing this work. 2 quick questions. One, which countries have IV bags available? Not sure. I know Chad, Central Africa, we only get it in hard bottles. And then, but any plastic bag would work. And then as far as how it spreads out under the fascia, that plastic tubing seems to spread out under the fascia pretty well, it sounds like.
Yeah, so to answer your first question, there's different kind of availability of resources in different countries. So the ones we know for sure are Kenya and Malawi that we've been able to confirm that they have these IV bags. But I think the beauty of engineering and just design is you can use whatever materials you have on hand. And then to answer your second question, yes, so the reason we used oxygen tubing is because it has enough of a recoil, so once it's kind of folded and placed under the skin, it expands to its original shape and really helps the bag to keep its shape and stand up properly. Thank you.
Thank you very much for the.
Sorry.
Thank you very much for the work that you're doing. Trying to make these bags locally. I think in the future that's going to be really, really important. But in the meantime, can everybody in this room save your silo and just mail them to me? Seriously, I mean, we go to Vietnam, we save our bags, and we take them to Vietnam. Everybody in this room's got a bunch of bags sitting around. When you use them, save them, wash them, and maybe we can just collect them and send them to these places.
How do you sterilize the bag after the use? How do you clean it?
Right, so in our lab, we used glutaraldehyde solution, and we submerged the bag in there. I believe there's also ethylene oxide or some gas that you can also use to sterilize bags as well.
Any other questions? Thank you.
Thank you.
Our next presenter is Dr. Greg Klazora, presenting a project titled The Pediatric Emergency Surgery Course, Impact on Provider Practice in Rural Uganda.
Thanks for the introduction. My name is Greg Klazora, and I'm a general surgery resident at Loyola University Medical Center. During my research time, I was a global surgery fellow at the University of Illinois at Chicago and UCSF, and the Fulbright program and the NIH Fogarty Center funded the work that I'll be presenting today. I don't have any disclosures. So the Pediatric Emergency Surgery course trains rural Ugandan providers to identify and manage critical pediatric surgical conditions. 45 providers took the course between 2018 and 2019, and we sought to assess the impact of the course at 3 regional referral hospitals, Fort Portal, Kabale, and Chewoko, all shown here on a map of Uganda. Also shown on the map are where the 2 pediatric surgery hubs in the country are, Mulago National Referral Hospital in Kampala and Mbarara Regional Referral Hospital in Western Uganda. So in order to assess the impact of the course, we performed a retrospective cohort study. Diagnosis, procedure, and patient outcome data were collected from the 3 regional referral hospitals and the 2 pediatric surgery hubs 12 months before and 12 months after providers from the regional referral hospitals took the course. We poured over thousands of records, usually using students or the records department in record books like this, to assess referrals to the institutions Mulago and Mbarara. More specifically, we used the Wilcoxon rank sum test to look at continuous variables. We used the Pearson chi-square test to compare pre and post-course measures. We used the interrupted time series analysis to assess referral volume before and after the case. And we used moving averages to assess the operative volume of selected cases. Over 1,500 admissions were recorded across the 3 regional referral hospitals, and the admission logbooks from these sites actually showed no statistically significant difference in length of stay, patient age, and discharge status before and after the course. We also collected 116 referrals from the regional referral hospitals in the Mulago and Mbarara admission logbooks, and that data is displayed in this table. These logbooks did show a significant reduction in neonatal time to presentation in the post-course period. Furthermore, patients referred for care were significantly younger in the post-course period. And finally, there were significantly more neonatal and infant referrals in the post-course period. We also used an interrupted time series analysis to assess monthly pediatric surgery referrals before and after the course. The method used ordinary least squares regression to obtain estimates of referral rates. The baseline referral rate from Fort Portal was 0.54 patients per month, and there was a significant immediate change in referrals seen after the course, with 0.77 patients referred per month, but this change stayed relatively constant and did not continue to increase. The baseline referral rate from Chiwoko was 1.36 patients per month, and the rate was actually decreasing by 0.18 patients per month. And there was no significant immediate change in the frequency of referrals immediately after the course. But there was a significant increase in the rate of referrals. The referral rate increased by 0.09 patients per month compared to decreasing by 0.18 patients per month. The referral rate from Kabale to Mbarara and Mulago showed no significant immediate change or change over time after the course. We collected over 2,100 cases across the 3 regional hospitals from the operative logbooks. None of the sites demonstrated differences in case volume before and after the course. However, the course encouraged qualified providers to perform selected cases in order to offload some of the burden of these cases from pediatric surgery specialists, namely hernias, pyloric stenoses, and intussusception. So we performed monthly moving averages of the combined number of these selected cases. The initial average was obtained by taking the average of the initial cases in the month. Each subsequent case averaged the monthly case volume over all previous months. And we chose this method because moving averages smoothed out short time fluctuations. Here, we see that each bar graph is a moving average of the combined number of these cases, hernias, pyloric stenoses, and intussusceptions performed each month. The thicker the line, the more cases were performed in that particular month. The number on top of the bar graph represents the moving average. And over the data collection period, there's an increase in each site in the average OR volume from the first month of the data collection period compared to the very last month of the data collection period. So our data suggests that the course increased referrals to tertiary centers, such as Mulago, where we see Dr. Kisa and pediatric surgery fellow Dr. Rovine in action, and increased operative volume of selected cases at rural hospitals, and shortened time to presentation of congenital anomalies at tertiary centers, all indicating that the pediatric emergency surgery course increases surgical capacity through improved referral patterns and increased operative volume for selected cases. Increased investment in local courses, such as a pediatric emergency surgery course, could significantly and immediately bolster capacity to manage pediatric surgical disease in Uganda and similar settings. I'd like to thank my co-authors and the surgeons at each site and the individuals and teams who helped me collect data, and the founders of the course, Dr. Kisa, Dr. Asgadiz, and the late Dr. Satuma, who Stephen acknowledged very nicely earlier, but I'd also like to take a moment to acknowledge the work he did. He really spent his life serving Ugandan children and families, and he's such an advocate for this course and for children in Uganda, and I was really lucky to work with him.
Greg, that's a great presentation of the impact of that course. I know it's previously been published what is included in the course, but can you say how that changed over the course's evolution and what they find most important to present now?
Yeah, so the course participants really crave hands-on training in our sort of qualitative analysis and work with them. So the course hasn't changed in its evolution so much in the lessons that have been given in the past few years, but there's now plans in place to offer more interactive lessons and build simulation models for future course participants.
Can I also ask, do you have any data on potentially increased complications, surgically or anesthetically, by shifting these certain procedures more to the regional hospitals?
So we tried to look at that. We wanted to look at if there was any difference in mortality rate. We didn't see any difference in mortality rate, and it was difficult to look at other markers of quality, such as surgical site infection. That granular level of detail in the data wasn't really available. So to answer your question, we tried, but we didn't really see any change in quality, either positive or negative before and after the course.
So I know this is a surgical conference, but in these communities, are you also working to incorporate the emergency medicine physicians and other members of the hospital team in these courses to educate the whole group?
That's a great question. So this course is geared towards general surgeons and junior surgical trainees. But there's efforts underway by some members in the audience right now to do like a congenital anomaly identification course, which local stakeholders think is really nice component and adjunct to this course to help improve referral patterns and identify pediatric surgical disease.
Great. Thank you. Our next presentation is titled Advancing Gastroschisis Care in Low-Income Settings, the Experience in Rwanda. This will be a pre-recorded presentation done by our colleague in Rwanda, Edmund Ntaganda.
Thank you for the opportunity to present our work. My name is Dr. Edmond Ntaganda, and I'm joining you from Rwanda. We have no disclosures. Greater than 95% of babies born with gastroschisis in high-income countries survive compared to less than 5% in low-income countries. The management principles are not complex, with most aspects achievable in even the poorest settings. Critical to the management of gastroschisis is expedient transfer to a center with pediatric surgical expertise. While there have been many international partners in Rwanda, the first comprehensive pediatric and neonatal surgical service in Rwanda started at CHUK in 2016. Prior to 2016, gastroschisis mortality was close to 100%. A dedicated neonatal surgical unit was opened in March 2020 in collaboration with hospital and international partners. You have already heard about our neonatal surgical outcomes registry, and we are an active training site. This is a single center descriptive study. We identified patients with gastroschisis before and after the opening of the dedicated neonatal surgical unit, utilizing both retrospective and prospective data. We specifically looked at epidemiology and demographics with outcomes as you see listed. To start, here is an overview of our current management of gastroschisis in Rwanda. A spring-loaded silo is placed by the surgical resident or pediatric surgical fellow at admission. These silos are donated by our partners and they are cleansed inside for sterilization between uses. The silo is reduced bedside by the pediatric surgical team until it is appropriate for sutureless closure. Nasogastric tubes are aspirated by nurses or with the help of families manually, and difficulty with intravenous access is the norm. 342 patients were admitted to CHUK with gastroschisis over the 6-year period, with 95% of them born outside the hospital. Overall, in-hospital survival was 31.9%. 47 patients had complicated gastroschisis, of which only 4 survived. Only 9 patients were diagnosed prenatally. The mean length of stay was 27.8 days for survivors. Looking at overall incidence, we used the total Rwandan live birth data from 2020 to estimate the incidence of gastroschisis in Rwanda at 3.8 over 10,000 live births. As expected, the incidence is higher in younger mothers. In our patients, the mean maternal age was 23.5 years, which was younger than the overall mean maternal age at CHUK over 26 years. The volume of gastroschisis cases increased more than threefold between the 2 time periods, from 2.5 to 7.9 cases per month. Relative in-hospital survival also improved 40% after opening the dedicated neonatal surgical unit, from 22% to 32%, with a p-value of 0.063. As noted by the blue bars, there was an increase in gastroschisis admissions starting in 2017. Despite a gap in data collection in 2019, the number of gastroschisis patients admitted per year continued to grow, with cases for the first half of 2022 exceeding all of 2021. Survival similarly increased as noted by the gray line with the right-sided y-axis. Rwanda's healthcare system and its capacity to care for surgical neonates has grown considerably since 2016. We believe this represents the largest cohort of gastroschisis patients from a single institution in a low-resource setting. Additionally, since opening a dedicated neonatal surgical unit, we have seen both increase in volumes and meaningful improvements in survival. Some ongoing barriers we face in improving gastroschisis outcome include lack of prenatal diagnosis, lack of durable IV access, and lack of parenteral nutrition. There are significant challenges with sepsis and antimicrobial resistance. An ongoing prospective neonatal surgical registry will inform future initiatives to further improve gastroschisis outcome in Rwanda and support innovation for neonatal care in resource-limited settings. We thank you for your time. As you can see, we have a large team that have collaborated for this ongoing project. I am available in the chat box, and my partner, Dr. Robin Petro, is available in person for any questions. Thanks again.
Our last presentation today will be by Dr. Ellen Cisco, titled The Global Reach of a Free Pediatric Surgery Education Initiative.
Thank you for the opportunity to present. We have one disclosure. And so the problem we're going to address in the presentation today is related to what we see as knowledge disparities. We know that there is a lot of literature coming out on a constant and daily basis, and it can be difficult to stay on top of all of this new knowledge for a couple of reasons. One being the sheer volume and just not having enough time to read all of it. And second, sometimes issues with access and difficulties. Some of these can be related to regional societies and journals and knowing what's going on in your region of the world, but not necessarily the others. And second, related to the costs associated with reading journal articles, joining societies, and going to meetings. We know that information technology has been really instrumental in enabling the spread of knowledge globally, and so we're discussing what we've been working on, a solution of knowledge dissemination using information technology. And so the way that we do this is we take pre-recorded lectures or journal articles, talks, we convert it into short, engaging content in the form of infographics, audio podcasts, videos, and then we share it with the entire world freely on multiple platforms, including a mobile app, the Stay Current app. We share everything we make in videos and podcasts on YouTube. We share all of our podcasts on multiple platforms. And finally, we distribute all of this through social media on multiple platforms. And we wondered, are people using it? Where are they coming from? Are we spreading all of this knowledge globally like we would like to? And so we reviewed the user countries on our app over the last 4 years, 2019 to 2022. The app was created in 2018. We reviewed the total views and by country on YouTube in the same years. We reviewed again the total listens and by country on SoundCloud during the same years. SoundCloud is a platform that helps distribute podcasts to multiple other platforms that you might be familiar with, like Spotify, Apple Podcasts, etc. And finally, we reviewed our social media followership over the last couple of years. We have less data available for the social media followership, but I'll present what we have. And so in our app, we can see that we have had good growth globally, starting with about 130 countries in the beginning of 2019 and ending with over 170 countries represented by the end of 2022. In terms of the number of users, when we first started back in 2019, we had about 4,000 users and have since grown to over 12,000 registered users on the app. In terms of how many plays we're getting on our videos and podcasts, we've again seen substantial growth. The red is total YouTube views, growing to over 137,000 views in 2022 alone, and on SoundCloud over 180,000 listens of our podcasts in 2022 alone. We aren't able to see as much data as far as all of the countries represented. They show us just kind of the top countries represented in our cities, but we can see, at least on SoundCloud and on YouTube as well, that we have good representation from all over the world and who's listening to what we create. Finally, social media, like I mentioned, we have a little bit less data available on these platforms, but we again have seen that we have good representation from all over the world on the platforms that we have accounts on Facebook, Instagram. We've learned that Instagram is really popular in South America and Central America, and again, we've seen good growth in the followership over the last couple of years. So we conclude that we have had substantial global growth for both our app users and our video and podcast viewership. We've seen that our pediatric surgical knowledge dissemination can be innovative and engaging, and we've seen that the surgical education can be made free and internationally available. For future steps and things that we're already working on in order to increase even more accessibility of some of this new knowledge coming out is that we're translating many of our podcasts and videos and infographics into Spanish with the help of our team member, Cecilia Gijena from Argentina. And more recently, some colleagues reached out to us and wanted to start translating some of our content into Japanese as well. So we've been sharing new videos in Japanese, and we look forward to more collaborators and more opportunities to share all of this new knowledge with the entire world. Thank you. This is some of the team I've been able to work with, and I'm happy to take any questions.
If I could ask, how could you increase your efforts to have this platform reach those populations that are most in need?
That's a great question. And we rely on kind of what is most used in the different countries. Like I said, we learned that in South America they use a lot of Instagram, and so like Cecilia has helped us to share it with colleagues there. And so I mean, learning what is most used in other countries would probably help. If anyone has ideas or platforms that we could share it with, we could certainly do that. We've talked to a lot of different people from other countries, and they've shared that sometimes our podcasts have been helpful to them in the content on the app.
Thanks.
Hi, Miguel Gefran from Chile. Thank you for your presentation, and I want to say thank you. I'm from South America, and how GlobalCast has impacted our knowledge in terms of how democratic it becomes in terms of money. Here in the United States, money is not an issue, but in the other countries, to get this information for free is almost impossible. So GlobalCast is doing that for us in terms of giving more democratic knowledge in terms of how they get this, all this information for free, majorly for the fellows and the residents. So thank you very much.
Thank you.
Thanks.
I'll invite our chair of the Global Surgery Committee to say a few words.
Really, I just wanted to pause to acknowledge this moment. I'm the chair of the Global Surgery Committee. I'm Jay Krishnaswamy. For many of us who've been involved in global surgery and academic global surgery and health equity and have watched the field kind of develop with time, we have seen it flourish in other organizations and grow as a field, and maybe we wondered when APSA would join in with this, and clearly that time has come. I think what we heard just now really showcased the scope of the problem and the innovative science that's needed to form sustainable solutions in these low-resource environments, whether that's internationally or low-resource environments here. I want to acknowledge that this wasn't just a bunch of abstracts. This was a plenary session on global surgery. And it wasn't just a plenary session, it was the very first plenary session in global surgery. So I want to thank APSA for allowing us this platform and for all the support in global surgery this year. And I want to thank our presenters for the incredible work that you're doing to advance the field, and Dr. Grant and Lyndon for moderating this very first plenary session. And then finally thanking our international guests who've come here. There's more and more every year. We also have our travel fellow, Dr. Khan, who will be seen tonight as well. Last thing I want to say is I want to please appeal to everybody as we go forward that in addition to the other venues that you send your work to and your international partners send your work to, please start sending them to APSA so we can see more of these sessions to come. Thank you.